This is a short presentation on perimesencephalic angionegative subarachnoid hemorrhage. In perimesencephalic non-aneurysmal subarachnoid hemorrhage, we report two cases. The first is VK, a 67-year-old female. She presented with sudden onset severe headache and vomits. On examination, her blood pressure was 150/90. Her GCS was full, giving her a World Federation of Neurological Surgeons grading of 1, and Hunt and Hess grade 1 or 2 because actually the headache was quite severe. This is the CT scan which we initially obtained. This shows a quite large pre-mesencephalic subarachnoid hemorrhage. Digital subtraction angiography did not reveal any aneurysm. The second patient was LJ, a 59-year-old female who was brought in altered sensorium. The Glasgow Coma Scale score was E3, V3, and M6, which would make her a World Federation of Neurological Surgeons grade 2, and Hunt and Hess would be also grade 2 to 3. She had no nuchal stiffness, but she had hyponatremia. Her husband used to complain that she consumed large amounts of water every day. This is a CT scan of the brain, which shows a comparatively small pre-mesencephalic subarachnoid hemorrhage. Digital subtraction angiography again did not demonstrate any aneurysm. Perimesencephalic non-aneurysmal subarachnoid hemorrhage etiology is not well established. It is believed by many that it is because of a venous bleed, not an arterial bleed. However, there have been proponents that it's a small dural AV fistula which is blood, or a perforating artery or a capillary might have blood, or a small thrombosed aneurysm. The clinical profile is usually headache and altered sensorium. Unlike aneurysmal subarachnoid hemorrhage, the incidence of rebleed is very, very low. However, patients can develop vasospasm. 50% of patients in whom we do a digital subtraction angiography for follow-up after about a week between day 4 and day 15 show angiographically demonstrable spasm of the basilar. However, delayed cerebral infarction incidence in perimesencephalic non-aneurysmal SAH is low. Patients have headache, which might be troublesome. We manage them generally with a BP systolic of between 130 to 150. We manage the pain. Anti-seizure medication is usually given. There is a role of nimodipine. However, nimodipine has a very protective role in aneurysmal SAH, not just because it prevents vasospasm, but because it prevents DCI, because of the other factors also which are involved in delayed cerebral infarction. Steroids may have a role in the relief of headache.